Hello, I'm Elvira Lang-Anderson, and I would like to share with you a talk I gave at the European Burns Association Congress 2023 in Nantes. I was very delighted to be among a distinguished panel where we discussed how communication within a team can improve patient outcomes. I started out in interventional radiology, where just like in treatment of burn patients, you apply potentially painful stimuli to predominantly awake patients. And when I first saw how an imagery or hypnotic process worked in a young Vietnam veteran with PTSD, I wanted to know, does this also work with other patients? So I built a research program surrounding that, and we very quickly found that the way teams interact becomes very important. Fortunately, we were able to obtain funding to test methods that would work well and conduct clinical trials. And after we found it all works, I founded a company, Comfort Talk. And this is among my financial disclosures. I also receive royalties on several books and an app we constructed. Now, in this talk, I will address how a key component of human interactions is the transference of emotions. One stressful individual in the room can raise the tension of everybody, and a stressful room results in poorer patient outcomes. So I will also share some techniques how to lower tensions for improved outcomes. Now, stress is contagious, and we looked at that in several of our clinical trials. So patients who present with a high negative affect, so these are the ones who say, oh, everything always goes wrong or things don't work out, they're kind of right. They're going to have more adverse events. And they also receive a lot more drugs, possibly because the team needs to calm themselves down too. We also did trials where we looked at the effect of pre-procedure anxiety. And when it is high, patients experience more pain. The procedures last longer. They get more drugs. Again, they have more complications. And there is something I'm more and more fascinated about, which is medically induced PTSD, and particularly in burn patients who undergo repeatedly a stressful procedure may develop even greater fears from one time to the next. Now, while stress is contagious, the good news is you only have to relax one person in the room. And the good news further is that when you train a team, and we did that with MRI teams, where we randomized 3 teams we trained and 3 we didn't. And here on this chart you see how in the trained team the patient satisfaction ratings went up, and this was sustained like over a year. At the untrained sites, originally good satisfaction decreased. And again, what also happened, and this was in a large urban territory with more or less saturated availability of MRI, was that patients started to get more to the trained places so they could maintain their throughput. And I think once staff notices, oh, we may have fewer patients, perhaps I will not be able to keep my job, their stress and dissatisfaction also probably rubbed off on the patients, hence the decreased patient satisfaction ratings. Now, how do we do that? We place a very emphasis on instant rapport, because keep in mind, these patient interactions are very short. So you have to feel how that patient feels within seconds, but then lead to a more helpful state. It also becomes very important to give a perception of control. Now, how can you do that, let's say, to a patient who is basically can't move away from the table they are on, from the bed they are in, with all their dressings? Well, you may still want to ask them, well, would you like me to start on the right side or on the left side? Would you like me to do this first or that? It gives the patient a perception of control, which we found to be very, very important. There's small changes in language to avoid negative suggestions like, oh, it's not going to hurt a lot, or how can I make it not hurt, or how bad was it? We showed in the trial that that will increase the perceptions of pain and anxiety. And yes, we use some hypnotic suggestions in a positive way. We may use imagery. Where would you rather be? And then include in what we do some suggestions. Sometimes we may add some specific pain management, and we may even do a formal induction. You can learn more about it on our other trainings on our website, comforttalk.com. And yes, we also use a script. And you see this here, it's 2 pages. It's relatively fast. And we use it also for training, because some of the sentences the individual trainee may just take and mention here and there. And if it's a longer case or a surgery or something that is very invasive, we also have some options to make the patient more comfortable and to address also potential anxieties. Now, if you want to hear how this script works, we do have it on the app. It's for free download on the App Store and the Google Store. It's called Comfort Talk Pro. Now, how can this work masterfully in the burn setting? And I learned a lot in that regard from Alex Chisholm. She is an expert in pain management and works in the burn unit at the Calgary Firefighters Burn Treatment Center in Calgary. And one of her patients, Dana, wanted to hear her story and how the way Alex approached her and the team and how their use of hypnosis and imagery helped her. And if you look at her history, she's young at that point. She had a motor vehicle accident with very extensive burns. She had 48 surgeries. She was 1 year in the hospital. And this amazing, remarkable woman made it through all of that with this incredible confidence. Now, how did Alex do it? I mean, for most of the interactions, she didn't need to use the whole hypnotic armamentarium, only some of the techniques I mentioned a little earlier. But then one day, the patient needed a feeding tube, and she used to spit those out, because keep in mind, if your body is burned, also the mucosa in your mouth is very, very sensitive. And since this couldn't be done with general anesthesia, because the patient has to swallow the device down to get it into the stomach, she came to the point where she said, if this cannot be done without sedation and me being out, I'd rather die. So Alex was called to come into interventional radiology and help her. And so that's where she did a whole hypnotic process. And this is the video that they recorded of how this went.
Anna, one of the things you did during your recovery was hypnosis and relaxation. Can you tell us a little bit about what that was like for you?
It was a chance to get out of my head and go somewhere more pleasant, like get off the task at hand, make it a little bit easier. Like when I had my NJ put back in, it didn't feel very good going down, but I was able to get out of there, and I was like on the beach with Diplo eating strawberries.
Because you had tried before to get it down and they hadn't been able to do it even though we'd given you a bunch of drugs. But when you took yourself into hypnosis, you were actually able to get that down in a really smooth fashion. Is that right?
Correct.
You did an amazing job, and I think that shows how it was your brain that did that. And would you recommend it to other people, that type of intervention?
Oh, definitely. It helps. Sometimes you could have as many drugs as you need, and it doesn't do anything. You have to figure out another way.
Now, why does this all work? We did 3 prospective randomized clinical trials and looked at the patients under standard of care. And here entering the room at time 0. And these were procedures of very different invasiveness. Vascular renal procedures, the green line, breast biopsies, which are done without sedation, and tumor embolizations, where we go through the arteries, we inject a large amount of chemotherapeutic agents, and which have higher procedural risks. And what we found is, as you see here, pain here recorded on a scale of 0, none at all, 10 worst possible, went up nearly linearly and pretty indistinguishable among the 3 procedures. And we found that was pretty independent of the amount of drugs given. However, if at the beginning of such a procedure you provide empathic attention in the shape of rapport and avoidance of negative suggestions, this red line that you would get under standard of care with an increase in pain is much flatter. If you add your entire comfort talk armamentarium with positive suggestions in the beginning, this doesn't happen. And the same for anxiety. It tends to go up under standard of care, is about in the middle with empathic attention, and with the full comfort talk, it decreases. And I can tell you it's a big difference if you work with a patient and in a team in a room after a while were the patient stressed out or not. Now also when it comes to treatment of pain, a question arises, why do we give the drugs? Is it for the patient or is it for the team member to feel not as stressed out about giving a potentially painful stimulus? You know, in burns, there's this added visual component of you take these dressings off and what you see below. We did a clinical trial where we found that institutional drug cultures are greatly determining. We had the same physicians do the same type of procedure at different hospitals, and matching the patients for the degree of disease, age, and what the procedure was, we found that the amount of drugs given, which was directed by the nursing teams on those sites, was significantly different. And if you attempt to change that institutional culture, you will encounter serious resistance because people will fight for the way they believe their way of managing pain is the right one, even if there are no data available. We also did a recent study here at Toronto Hospital for Sick Kids, where we showed that children who had a hypnosis script read before they went into the operating room for treatment of heart arrhythmia under general anesthesia, anesthesiologists subconsciously gave much less drugs than to the other children, although when they were asked upfront to evaluate the children on a numbering system of how they felt, they didn't evaluate them differently than the others. So there are interesting subconscious components involved. What that also means that if you do train skills in how to improve teams' communication patterns, you have to expect and also manage resistance. We found it very important to include different stakeholders, champions, but definitely also objectors. Some of our biggest objectors have become the biggest proponents of comfort talk in their clinical settings. And once you train the teams, it's best to also include these communication skills during onboarding of new hires. And this is currently very successfully done in the Dutch Bevolkingsonderzoek, which is the national breast cancer screening program, where we developed their in-house trainers who now, when they have new teams come, also include a comfort talk. In US, we use this additionally for the training of residents through the accreditation for graduate medical education. And the nice thing about it is that everything we teach is based on observable and teachable behaviors. So we were very fortunate that early on, and that was due to our grant funding through NIH, we had to make sure that we showed what are we teaching. Is it observable? Can you catch it on a video? Can we say our trainees actually learned this? So we cut down our training to such behaviors. But then with subsequent funding also made it possible to design a teaching template that made sure that we could train trainers that then in turn led staff to display these desired behaviors which had desired patient outcomes. And then as a last step, we developed a further program where we showed, yes, we can train trainers that train these individuals to become efficient teachers for the staff that then will display the desired patient behaviors and outcomes. Now, one additional point right now is we have the big resignation. We went through COVID. It has caused tremendous pain and hardship on people working in the medical health care. And it becomes critical to make work fun again. And you do that by minimizing disagreeable components, but also have patients appreciate what you do. What we find more and more, what makes patients come back, when you leave home and you have the feeling in the evening or after night shift in the morning that you made a difference in at least the life of one person. Ideally with having invested extra time and energy. And that this person appreciated and you saw this clear difference. That is when you are coming back. And that's what we are striving to do with Comfort Talk these days. And here is one more video to show how this panned out when the patient you saw earlier with her treatment through Alex and in this whole team, she wanted to say thank you, and this is in Canada, she wanted to do it as a dance with the firefighters. And here you will see this entire team coming together and celebrating the patient's recovery. So thank you for listening. If you have any questions, please contact me. There's a phone number. You can email at comforttalk.com. Go on our website, see what other potential training opportunities are there. We have online courses, we have the books, we have the free app. And I wish you all the very, very best in your clinical endeavors. Thank you.